and gentlemen, first I'd like to thank you and the organizers for the nice invitation to talk about immunoglobulin therapy, especially about personalizing the treatment with immunoglobulin therapy. This is my disclosure. So, why should we personalize high disease treatment? I will give an introduction, look at it from the patient's perspective, we look from the doctor's perspective, and also what limits the well-being status of patients who are receiving immunoglobulin, and I will make some conclusions. Primary immune deficiencies are rare disorders by each of them, actually, but together they are still quite frequent, comparable with Crohn's disease, for example, and that's about 1 in every 1,200, 1,500 in the population. Most of these defects are antibody production defects, as shown over here. Further, cellular defects, complement defects, and also defects of the phagocytes. The first one who started immunoglobulin therapy was Bruton in the early 50s. He treated a boy with immunoglobulin preparation they made at that time and injected him intramuscularly because the patient was suffering from respiratory infections and also sepsis recurrent. They showed this was a very successful therapy. Later, in the beginning of the 80s, a new preparation became available, the intravenous immunoglobulins. With the therapy, you could treat your patients once every 3 weeks, 4 weeks with an immunoglobulin dosage every month, and that prevent them more and more from infections. In the early 90s, the subcutaneous immunoglobulins became available, and it gave patients more freedom to inject themselves. One of the latest developments is a kind of subcutaneous immunoglobulin substitution, but after injection with another compound. I come back to this later. This therapy in patients with hypogammaglobulinemia is quite successful. It decreased significantly the mortality in patients with this disease. In our country, we are using intravenous immunoglobulins, the 5 and 10% preparation, and we inject that directly into the blood vessel with an infusion. Or subcutaneous, we are using the 20% formulation directly through the skin. And then we have another opportunity to inject the patient first with an enzyme that makes space beneath the skin, and then add subcutaneously the immunoglobulins. And I show you over here, when you inject the enzyme with this difficult name, that makes more space, temporary, and then we add subcutaneously more immunoglobulins, so we can repeat this every 3-4 weeks, like the intravenous dose. When we look at the blood levels in patients who are treated with IVIG, subcutaneous, or the facilitated subcutaneous, you can see this over here. Subcutaneous is a more steady immunoglobulin level. I'll show you over here. While intravenous gives a peak. I show you over here. And many people, there are patients that suffer from headache or systemic side effects that may be related to this peak. On the other hand, we do not know if this peak is necessary to suppress unwanted inflammation, but that's not quite clear. So actually, subcutaneous reduces side effects like headache and other systemic adverse events, but on the other hand, intravenous immunoglobulins are well tolerated by most patients. An important difference is that you need blood vessels, venous access, in patients to administer intravenous immunoglobulins. And you do not need this for subcutaneous. On the other hand, you have to repeat it in smaller periods than intravenous immunoglobulins. That's not for facilitated, because you can use that so every 3-4 weeks, and some patients from our hospital went from IVIG to the facilitated because of poor venous access or some side effects, or want to travel longer than 4 weeks. Or on the other hand, patients who were treated with subcutaneous and who changed their treatment to the facilitated one want to have only 1 needle stick per month. Or it has something to do with traveling freedom, but there are also side effects. Infusion site pain, including swelling and discomfort beneath the skin. Accumulation of fluid, and that takes a few days. And very important, and not at last, technical troubles, because you have to inject yourself first with the enzyme and then the immunoglobulins. So what to choose from a patient's perspective? You like to have freedom as a patient. You want to go to school, you want to go to your work, visit your friends, family, want to travel, and you want to have no side effects, actually. Factors that are important. Are you getting the immunoglobulins in the hospital or infusion at home? In the hospital, some patients like the social aspect. You see other patients with the same disease. You can exchange information, but you have to travel to the center. When you get home infusion, you don't have to travel, but you have not all facilities compared with the hospital. So who decides what immunoglobulin therapy you get, intravenously or subcutaneously? This is mostly a combination of the doctors and the patients, and also supported by their partner and also the nurse who is involved. Is, in my opinion, also important. This is a multinational study, so this differs per country. When you are treated with subcutaneous immunoglobulins, it's usually at home, while intravenously is infused in a hospital or a specialized clinic. When we look at the time, the duration of this therapy, at first subcutaneous. Subcutaneous is at home, so you have to prepare yourself for about 20 minutes. The process takes something like 2 hours or 2 hours together, and that's quite fast. And you have to inject yourself once a week or 2 times a week, completely depending how much immunoglobulins you need. When we look at intravenous immunoglobulin therapy, depending on the country, again, you have to travel to the hospital or wherever. You have to wait in the hospital. That's kind of normal. Then you get the infusion, and that takes sometimes to 6 hours. However, it depends. When I look in my country, the hospital is sending the immunoglobulins to the house of the patient, and we have home care organizations that come to the house of the patient or bring us the immunoglobulins. They bring the pump and give the infusion over there. So that's quite comfortable, and maybe that's the reason that a lot of our patients want to stay at intravenous therapy, actually in my hospital. What are our patients doing during immunoglobulin infusion? They're watching television, reading, of course, and probably the younger ones are playing with the computer or the telephone. Some people are eating, so you can say maybe you get fat of immunoglobulin therapy. So that is how they spend their time during the treatment. The venous access is very important, and you need the infusion needle, and in the first time to take a few attempts to get the infusion into the blood vessel. But in time, with trained nurses, it's going quite well. So the choice of what kind of immunoglobulin therapy, and maybe what kind of brand you choose for, depends. Depends on inconvenience or flexibility, the side effects, freedom, depends on your job and or your school, and so this is quite individual. When we look to what the doctor thinks what's important, that's also, of course, it's for the doctor also important that the patient has freedom and have the best therapy they like, but there are other issues. So, for example, the comorbidities, so other diseases patients have. You have to imagine patients are getting older, suffering also from general diseases like diabetes, heart disease. Maybe it's going more difficult when you get older to infuse yourself, so that's important, comorbidities. I'll come back to this a little bit later. The venous access is, of course, also important. The costs, and is there a product available that we can give at home, or we have to give it in the hospital? Or do we like to see the patient in the hospital because of the comorbidities and the reaction on a medical product? And do we need local facilities, and do we need the team? We like to have an infusion by a professional, of course, a well-trained nurse. I mentioned already the complications and the age of the patient. We need to know about the compliance, and that parents want to inject their children when they administer subcutaneous immunoglobulin for the therapy. Patients, for example, with congestive heart disease is also important, because when you have a heart disease, it can be difficult to administer a high volume of immunoglobulins into the blood vessel, because the heart has to pump it around, and that can be difficult. Skin conditions, when you have a skin infection, it's not good to, or a generalized skin disease, you maybe have side effects from a long-standing needle. Clotting disorders are important, and the renal function. Immunoglobulin therapy and what limits the patient's well-being. We mentioned this already. There's a difference in the quality of life of patients who are using subcutaneous immunoglobulins or intravenous immunoglobulins. But you ask it to a certain group of patients in a certain country. Multinational, what I mentioned before, the people who responded to this survey, that make also a difference, are more convenient with subcutaneously, and because it don't interfere with their work or school, and also no travel time. But it's quite individual. When we look at the quality of life of our patients, the general health, I focus on this. Then you see that patients with common variable immunodeficiency are over here, much lower than the general Dutch population, and even lower than cancer. That's something. We are doing everything to increase the quality of life of our patients, but still they are patients. They have to counter on their immunoglobulin substitution. They have to take care when somebody has an infection or live, especially these days, in quarantine regularly. And So you can imagine there's a lower quality of life. To compare this with another disease is always difficult because patients with cancer may have another perspective, future perspective, than patients with CVID. The comorbidities are also important about the quality of life, because when you have an anemia, you don't feel very good, or a risk of bleeding, or you have a non-infectious inflammation in your lungs, which give short of breath, and you're treated or not treated. You need to be treated with glucocorticoids or other drugs, which have also a side effect spectrum. We have to take that also in regard, and these conditions have also an effect on the quality of life. To improve that, a multidisciplinary team in the treatment of patients with PID is important. The organ specialists like ENT and pulmonologists are important when there is a severe lung involvement, for example. A psychologist to help patients to accept their disease and how to go on with it. A geneticist to make the diagnosis, and a nurse practitioner is extremely important to take care of the patients, apart from the internist or pediatrician, who is the central specialist treating patients with PID. A last slide about the future. We are taking care of our patients by examining them, interview them, and do also the physical examination. But the future, we maybe will give more perspective. We know the genes, we can measure the genes, we can measure the proteins. So in time, I expect that certain genes which are involved in the immunoglobulin remodeling explain better how many immunoglobulins a patient needs, the half-life of the immunoglobulins, meaning the degradation of immunoglobulins in a certain person, also explain more about the disease and explain more about the comorbidities and how to treat the patients who have a comorbidity like a non-infectious lung disease. So more factors will be done and more factors have to be studied before we implement this in our patients. So I end up with the following conclusions. PID, we have to take regard of the burden of inflammation, the burden of treatment. Psychological issues and social issues are important and maybe underestimated sometimes in patients with PID. Many patients, several studies indicated that subcutaneous is preferred above IVIG, but that depends on the individual and the local situation, as I mentioned. Personal medicine in PID, how you want to live is your therapy in agreement with your life as far as possible. Tailoring of the treatment is very important, and tailoring, looking at the individual characteristics and the needs of the patient, and maybe in the future by more genetic and other analyses to see what is the best therapy for the future. But that's future. I thank you for your attention, and this is our Immunodeficiency Center in Rotterdam, the Netherlands. Thank you.